This session is themed Equity in Healthcare Practice Models. It is titled Challenges in Providing Equitable Non-Communicable Diseases Care in Tamil Nadu. Our speaker is Dr. Sudharshini Subramaniam. We invite Dr. Sudharshini for this talk. We also invite Dr. Divya Mulel to moderate this session.
Good morning, everybody. I'm Divya Mulil, and I work in the Department of Community Health. And I'd like to thank the organizers for inviting me to be here. Our next talk is Equity in Healthcare Practice Models, and we'll be hearing from Dr. Sudharshini Subramaniam. Dr. Sudharshini Subramaniam is currently an associate professor in the Institute of Community Medicine, Madras Medical College. She's also an honorary consultant at the Rural Women's Social Education Center and a member of Nodal Point. Apart from her involvement in UG and PG training programs, she's also a resource person for qualitative research methods and applied psychometric workshops for postgraduates. She has 40 publications in national and international journals. Her interests include health system strengthening and health equity. She also has authored chapters in 2 different books addressing this very same issue. I'm very happy to welcome Dr. Sudharshini for this talk.
Thank you very much. Thank you, the organizers for giving the opportunity to talk here. So I would first establish my position here. I am working in the government sector as an academician, teaching community medicine for postgraduates and undergraduates. And I'm also involved in many of the programs implemented by the state government as a not only as an implementer, but also as a program evaluator. And I also provide clinical services, especially with a focus on NCD in NGO called Rural Women's Social Education Center, which is an NGO which is basically working for the vulnerable group SC women population in village near Chengalpet. So with this position, I would be proceeding with my talk on the challenges in providing equitable NCD care in Tamil Nadu. So I'm sorry if there are many repetitions, because I know you would have seen these figures coming quite often. So we know we have moved, India as such has moved from the communicable diseases to the burden of non-communicable diseases, and the risk factors are, earlier it was underweight, but now it is high blood pressure, tobacco, and alcohol. And if you look at the NCD prevalence in India, taking the burden from, taking the data from ICMR, NCDs were contributing to 40%, and now it is contributing to 68% of the total deaths. So with focus on Tamil Nadu, so again, this is from the global burden of disease. There has been a huge shift from communicable diseases to the non-communicable disease. Ischemic heart disease, diabetes, and self-harm are the top 3 causes for death in Tamil Nadu. So the risk factors again have shifted from malnutrition and poor sanitation and hygiene practices to dietary risk, high fasting plasma, and high blood pressure. So this is again data which is coming from the state government. This is the data on the utilization of the insurance packages. Of all the packages, the most commonly used package is the hemodialysis, maintenance hemodialysis for chronic renal failure. So this tells us, where we are heading to. So the NCD is a huge burden, and the need to address this NCD is very, very important. And if not, we are going to pay in terms of paying for the complications which comes out of the NCDs. So again, going to the theme of NCD, going to the theme of this conference as such on equity, the social determinants play a huge role in NCD. So there is a saying that poor make poor choices. Yes, poor are making poor choices. It is not because they want to make the poor choices, but the poverty pushes them to make poor choices. So to asking anyone to go for a walk, 30 minutes walk in the morning is a luxury for a poor man or a woman. So if you look at the lifestyle of a rural woman who has to wake up early in the morning, finish the household chores, and then engage in other activities, and then asking her to spend 30 minutes of her time for walking is, it's a huge luxury for her to spend that 30 minutes of time. And similarly, I mean, not only that, but also the kind of environment and the additional services that we provide for them to have a safe space for walking or engage in physical activity is not that great. Health, I mean, asking them to eat healthy diet. I mean, they would want to eat healthy diet, but the household budget doesn't allow them to go and buy the vegetables and fruits that we ask them to take 5 times a day, 5 servings a day. So the current PDS is largely dependent on the rice, which we know that it is also increasing the risk for non-communicable diseases. So poor people are at risk. They have the higher proportion of the risk factors, which in turn poses them at a increased risk of getting these non-communicable diseases. But it doesn't stop there. These people, the vulnerable people and the socially marginalized people, are those who do not get identified by the system early. So the time they are identified by the system, they are already in the complications, which is again going to cost them a lot. And the cycle is going to be repeated. So poor becomes poorer. And that is how NCD is contributing to inequity. So inequity contributes to NCD, and NCD in turn contributes to further aggravates the inequity. So this report by Oxfam, it has a report on inequality, how India is, I mean, on various determinants like caste, class, religion, what kind of inequity we are seeing. And with respect to the risk factors, this report has given that there is a huge disparity in terms of risk factors as well as in terms of the diseases as such. So given this, coming to the context of Tamil Nadu, so this was the survey which was done by Tamil Nadu government, called use the WHO STEP survey. It was done in the year 2019 to 20. So they found that 1/3 of the adult population in Tamil Nadu are hypertensives. Of these 1/3, only 1/3 knew that they had hypertension earlier. And only 1/5 of the hypertensives were on drugs, and only 7% were under good control with regards to hypertension. Similarly, for diabetes, 17% was the prevalence of diabetes according to this WHO's, the ICMR STEP survey. Of these people, only 50%, less than 50% know their diabetic status. And only 44% of the diabetics, that is again less than 50% of the diabetics were on treatment, and the glycemic control was 14%. So it stops there. We didn't look at the complications related to diabetes. It was not studied, but we can make an assumption on what would be the burden of the complications, having not addressed the key issues here. So then government of Tamil Nadu made it a mandate that there needs to be something done so that we are addressing this problem of diagnosing early and putting people on treatment earlier. So Tamil Nadu, along with the World Bank, they have this program called as Tamil Nadu Health Systems Reforms Project. It's like a disbursement linked indicators. So there are certain indicators which have been fixed by the government. A consultative process had been done, and we have fixed certain indicators which we are trying to achieve at the end of 5 years. So one such indicator is with regards to non-communicable diseases. What is the indicator? It says that the percentage point increase in the share of hypertensive adults whose blood pressure is under control over the previous survey. We are expecting 3-point increase in the hypertensive good control. And similarly, we are looking at an increase in the good glycemic control over a period of 5 years. So if we achieve this, we would be getting a loan from World Bank. So this is the agenda. So we have this data on 2019-20, and currently Tamil Nadu government is going in for the second STEP survey. So we are looking for a difference of at least 3 points and 10-point difference in the good hypertension control and glycemic control. But to achieve this, what was the intervention done? So Tamil Nadu government had been looking at various strategies with regards to NCD control over a period of years. It started from 2005, wherein again, with the World Bank project called Tamil Nadu Health Systems Project, we thought of working on non-communicable diseases. And then there was a program called as Nalamana Tamilagam, wherein people were raised awareness on the importance of maintaining the body weight, physical activity, all the lifestyle management was insisted. And then we had this program called as establishing NCD clinics in all the places. So the focus then was providing opportunity screening. So anybody more than 30 years of age, whoever is entering into a government health system, that is the opportunity for us to screen them for diabetes and hypertension. So that was the model that we had. So it was like a nurse-run model, wherein there was a staff nurse who would be stationed in the PHC or in government hospital or in a medical college hospital. So everyone who is entering into the PHC, they could be a patient or the attenders of the patient. Anyone above 30 years, they were screened for hypertension and diabetes. So that was the opportunity screening. Again, a passive screening methodology was adopted. But then we know that we have not covered a lot, because the chances that any adult would enter into a hospital, that to a government hospital, was not the probability was not that high. So therefore, and also during the COVID time, we identified the system was not able to, the system did not have the line list of people who are diabetic or hypertensive, because during COVID times, the government wanted to reach out to the people to deliver the drugs, because during COVID time, there was a lockdown and people were not able to move out to get their drugs. So government planned for reaching out to the doorsteps to deliver the drugs. And it was then they decided, okay, this can be a model which can be expanded to provide NCD care services. Instead of stopping with opportunity screening, we need to move to active door-to-door screening was the plan that was established. And with that plan, the government initiated this program called as Makkalai Thedi Maruthuvam, which is like delivering medicines to the people at their doorsteps. So this is again one of the flagship program of government of Tamil Nadu. And under this program, around 10 different services are provided under this program. One is screening for diabetes and hypertension at doorstep, screening for or mobilizing people to get themselves screened for cervical cancer and breast cancer, and drug distribution for hypertension and diabetes. And it doesn't stop there. It is also providing physiotherapy services, palliative care services, and providing CAPD bags are provided for patients who are requiring dialysis. And they are also screened for symptoms for COPD and CKD. And this model is also used for screening for other communicable diseases like TB, leprosy, and mental health is also packed within this MTM care services. So it is basically a community-based intervention wherein we are trying to provide all these services at the doorstep. But who is going to deliver these services? This program has got two components. One is the field component and the other one is the institution component. So I'd come to the field component later. And the other key features of this program is just to deliver home-based healthcare services. We cannot expect people to come to the health system to get themselves screened when they are apparently healthy. So we have to reach out to them. So home-based healthcare services was insisted under this program, and to ensure continuum of care services. So just screening in the field, labeling them is not going to help. We have to ensure that there is a continuum of care of services for those who have been screened positive. And it is looking at the needs of a household as a whole. It is not looking, this program, at least it is the vision of this program is to look comprehensively at the needs of a household. And the system itself has got multiple monitoring and evaluation mechanisms within that. So, one of the, lacunae that was felt by the government then was there was no proper digital records maintained. And here under this program, they are also trying to introduce a registry called as Population Health Registry, so that within, for every PHC area, all the population would be enumerated within this Population Health Registry, and all the data related to their health would be documented in that. And whenever a person is moving from one place to the other place for availing health services from a PHC to a medical college hospital, using this Population Health Registry ID, they would be able to track on what was the services that was received elsewhere. So, field care services is being delivered by a person called as Women Health Volunteer. They are self-help group. She's a woman from a self-help group. For every sub-center area, one women health volunteer would be identified. She is being trained on providing all these NCD care services, and she's also equipped with necessary equipments for providing the services at the field. So, this women health volunteer is the person who is delivering the field level services in the field level. So this is the actual model. So the women health volunteer, she works in coordination with the VHN or the mid-level healthcare provider who's there in the health and wellness center. And she does the screening for diabetes and hypertension. She is also responsible for dispensing the medications to those people who's catered within her area. So for all patients who have been diagnosed with diabetes or hypertension or any other non-communicable diseases, they are being issued a card called as the MTM card. And the copy of this card will also be maintained in the health institution. And health subcenter data would be pulled into the PHC, and from the PHC, the pharmacist would do packaging for dispensing the drugs to the health subcenter. From the health subcenter, the women health volunteer would get the drugs, and she would be dispensing it to the people at their doorstep. So all the drug indenting, everything would be done at the level of PHC. So this women health volunteer, she delivers these services in the field. She is responsible for dispensing the diabetes and hypertension drugs, and also she gives off the CAPD bags to patients who are with CKD. She checks the BP and blood glucose level at the time of dispensing the drugs. And it is not that every time the beneficiary would be getting drugs from the WHV. So every 3 months once, the patient is asked to visit to the PHC to get a medical officer, to be evaluated by a medical officer, and following which the WHV continues to dispense the drugs at the doorstep. And she informs and orients the beneficiaries about seeking any assistance through e-Sanjeevani, teleconsultation possibility is also there. And she's also linking with the other programs which is existing within the field. Like if she goes to a household and if she finds any child with any congenital anomaly, she refers to the RBSK, the school health, the child health program, and she links it with the other programs as well. So in institution, again, this MTM clinics, or otherwise called as the NCD clinics, are there, which provides still continues to provide the opportunity screening and confirm the diagnosis of diabetes or hypertension, and initiates the drugs. And for follow-up, MTM clinics or the NCD clinics are used. So this is the intervention that the government of Tamil Nadu has tried. Whether this intervention has actually helped in covering the gap, yeah. A process evaluation was done by ICMA-NIE, and the questions that they asked were whether this doorstep delivery of MTM services has reflected in the pattern of indenting the oral hypoglycemic agents and hypertensive drugs, and whether there has been a change in the utilization of the health facilities, and what kind of problems or the challenges that are there in the process of implementing this MTM. So the findings were like this. So there had been a decline in the drugs indented in the medical colleges and the secondary level hospitals, whereas there has been an incline in the amount of drugs that had been indented in the PHCs. So definitely this program has made people to avail the services of PHC, and it had prevented people from moving to the higher facilities, rather get it at their closer vicinity. So both for anti-diabetic and anti-hypertensives, the scenario is the same. So the drug indenting had declined in medical college hospitals and secondary hospitals, but it had increased in the primary health centers. So the pattern of utilization of health facilities compared to 2018, there had been a 92% incline in utilizing PHC services. So providing a women health volunteer in the field was able to mobilize more people to come to the nearest health facility that was available than going to a tertiary care center. So this intervention has really worked well in terms of these two indicators. And this evaluation also found that there were certain challenges in terms of how a WHO is being trained and whether they are actually good enough in identifying diabetes or hypertension, whether they are good enough in providing IEC materials for control of diabetes or hypertension. And they found that there was a challenge, there was a lacune, and many of the WHOs, because of other challenges like not getting their incentives, there was a huge, people were leaving the jobs. So therefore, there was a need for continuous training and retraining of the WHOs, and therefore, the government of Tamil Nadu also decided on a framing of, a flip book to train the WHO, and this was used as a job aid for the WHO to take it along. So then, the Makkalai Thedi Maruthuvam also claimed that they had reached out a lot number of people, screened them for diabetes or hypertension, and they have also claimed that a lot number of people are getting the benefits under the scheme. So there were doubts about these numbers, and therefore then State Planning Commission insisted on finding out whether whatever that was claimed by government of Tamil Nadu was true or not. And therefore, State Planning Commission invited Institute of Community Medicine, Madras Medical College to do a survey on finding out what proportion of people have been reached out by the MTM care services. So the findings are like this. So almost 3/4 of the people who were included in the survey know that there exists a program called as MTM. And if you look at the differences based on gender, there was no gender difference. Based on locality, rural population knew that there exists such a program, but urban population, the awareness was less. And similarly, when you look at the caste category, the SC, there was no difference based on caste category. But further dissecting that data, within rural population, there is a huge coverage. But in urban population, who has not been covered, it is the most vulnerable in the urban population was not aware of it. So the urban ST women were the population who were not aware of the MTM services. So yeah, one reason that we identified was in rural, the government health system is pretty strong in rural area. There is an existing system already. There are huge field functionaries who are working within the rural health system, but urban system is just an evolving system. So the because of the poor health system, which is there in urban area, the most vulnerable were not being able to be reached out by the health system in the poor urban healthcare system provided. Similarly, ever visited by MTM functionary, we can say that urban area, there is a poor coverage by the MTM field functionary being visited. And SC/ST was covered more. Again, an intersectional analysis showed that urban ST women were not reached out than the other group within the urban area. I would also put a disclaimer, but because the numbers N is going to be, the denominators are small because the project was not planned to do an intersectional analysis, but yet this information is very important because it is not all urban people are not covered. It is the most vulnerable within the urban area who is not being covered. So ever screened for diabetes, again, just to quote few examples, the urban women ST were least covered compared to the other population. So the point that I would like to make here is the presence of a stronger health system can reach out to the most vulnerable. So rural area, we had these examples. So in the with the stronger rural health system, we are able to reach out to the most vulnerable population. Whenever the health system is poor, whenever the health infrastructure is poor, the people who are going to be most disadvantaged by that is the already vulnerable population. So that is very clear in the evaluation that was done by the State Planning Commission. Having said that, there are huge successes which has been demonstrated by Makkalai Thedi Marthuvam. Improved accessibility to healthcare services for many, which again the ACMI study showed. A large number of people had been diagnosed with diabetes and hypertension, and many of them have been put on treatment. There is a huge reduction in out-of-pocket expenditure. Again, the State Planning Commission, the study, it also came up with the out-of-pocket expenditure and showed there was a reduction in the out-of-pocket expenditure with regards to NCD. And there had been a shift from private to public healthcare facilities because people know that these drugs are available free of cost in MTM, and they're also getting the drugs at their doorstep. They need not go to the hospital to get their drugs. So there has been a shift from private to public health system for their NCD medicines. And delivery of services through skilled health workers is a possibility now. And there is an increased community participation because the WHO is coming from the community. So there is a kind of larger engagement by the women health volunteer to deliver the appropriate services to her own people. Having said that, there are certain challenges, and these challenges are put forth not by me, but by the system as such. The Directorate of Public Health, they they reflected on the program as such, and they had written a paper and published in the journal called as Tamil Nadu Public Health Journal. So the challenges that had been identified by the system as such are the challenges with regards to human resources. The WHO, they are called as volunteers, and they are supposed to be paid honorarium for the services that they are being rendered. There was a huge gap in terms of time in the payment of their honorarium. And therefore, they had, many of them had left the, they didn't want to continue as a WHO. And in many places, there were people who, in many areas, there was no WHO at some point of time. And screening for NCDs. So WHOs, they don't have a fixed timing. So she can decide when to go and when to screen. So here what was found was most of the people who had been covered by WHOs were women. So the time during which the WHO visits the home, mostly the women population were there in the household, and the men population had already left for job. So there was a lacune in terms of covering the men population. So having identified this as a challenge, again, one more component of MTM which is now coming is workplace-based screening. So we have identified workplaces where MTM services would be provided within the workplaces. And there was, one more challenge that was identified was follow-up. The referral linkage was not very proper. So if a person comes to a MMC and he or she has been identified as a diabetic or hypertension, we want to refer them back to the PHC so that they are going to get the services there at their PHC. But this referral linkages was not that great. Though we had the system in place, the population health registry, it was not actually catering to this particular need. And delivery of drugs and dialysis bags, though it is said that it is the role of the pharmacist within the PHC to intend and do all the packaging and give it to the WHO in the health sub-centers. There were occasions in many of the areas where WHOs were asked to do this job. There was a lot of job shifting that was done here. And with regards to reporting, I know for any intervention to know whether it is working or not, data is very, very important. But with regards to NCD, we had multiple reporting systems. So there was something that was asked by Government of India. There was a NCD portal given by Government of India. There was this MTM portal given by Government of Tamil Nadu. There were multiple N number of portals, which the WHO, the VHN, the HA, the medical officers, all of them had to fill in all these multiple portals. So most of their time was spent on filling these reports rather than delivering the services. So there was a dire need for identifying one reporting system so that people are not duplicating the actions. And monitoring and supervision, there was, because of this lack in, proper reporting system, there was no proper monitoring and supervision. There ad hoc meetings that were going. There was a weekly review meeting that was conducted at each levels, but there were no real-time data which helped us to monitor what is actually happening in the field. And the MTM was largely focused on curative services, but we all believe that MTM should also focus on preventive and promotive services. They should engage a lot in providing IEC services. So we have also identified that just giving a pamphlet is not going to work, but a lot of other innovation should be incorporated in providing these IEC materials. And with regards to the urban-rural divide, we know the lack of proper infrastructure in the urban system is not allowing us to reach out to the most vulnerable population. And therefore, the need here is, even if WHOs are posted everywhere, the lack of a proper infrastructure within the urban health system is not going to allow us to bridge this gap. And the other reasons why there is a urban-rural divide is the population density, and these community health workers who have to work in the field are very new. They do not have, adequate knowledge about the area, and they do not have experience about how to deal with the population. And a lot of dynamic and migrant population in the urban area, which also restricts the system to deliver these services. And here in urban area, we have too many facilities. A lot of private healthcare facilities as well as the government health care facilities, but very limited outreach, which also limits us from reaching out to the vulnerable population. The other challenges are inadequate facility readiness and provider preparedness. So all the facilities, at every PHC, we have medical officers, but our undergraduate system, medical education system have least prepared them for handling this diabetes or hypertension case, in the PHC level. We know in a PHC, we have insulin, the pharmacy has insulin, but medical officers are there are not very confident to start on insulin. They are comfortable with initiating the drugs, but they are not comfortable with escalating the drugs, how to modify the drugs, when to start on insulin. Just for the purpose of starting insulin, most of the patients are referred from a PHC to a medical college hospital. In a medical college hospital, the patients tend to get lost, or otherwise they don't even go to medical college hospital. So they continue to be with the poor glycemic control, and fearing the medical officer in the PHC would shout at them for not going to the medical college hospital, they stop going there as well. So this is further aggravating the problem of poor glycemic control or poor hypertension control. Interrupted supply of drugs and medical equipment. So when MTM was started, a large number of people were screened, and therefore the system had large number of new diabetics and hypertension. The system was not prepared for such huge hike in the number of diabetic and hypertension. There were moments where the system had less number of drugs and less number of equipments to handle the situation, but now currently it is getting set right. Inadequate use of patient medical records. So we know that there exists something called as population health registry, but how do we use that for the benefit of the patients is still not that very great. Improper adherence to standard treatment guidelines, and lack of standard counseling messages. So we know that we have to counsel the patients on what to do and what not to do, but there is no standard counseling messages. So each patient, every time they visit a health facility, they get different messages. And we are stopping with screening for diabetes and hypertension. There is the infrastructure has very poor system in place for screening for early complications. So the way forward is the medical education system should focus on preparing the students for managing these public health problems. We know that NCD is going to be with us. A large number of patients, whether you are a surgeon or a physician, you are going to see a diabetic or a hypertensive. So for treating diabetes and hypertension, every time if you're going to refer to a physician or a diabetologist, we are actually burdening the patient. So I think as an undergraduate, everyone should be confident enough to treat these major NCDs. And we need to improve the managerial skills of the students as well, because we find a lot of problem with indenting. Because we have lack of knowledge on how to indent, the patients are the ones who are not going to get the drugs. So the undergraduate medical education system should also insist on training the undergraduates for these managerial skills. We should have a proper digital monitoring platform. Again, we have this drug distribution management system in place, which helps us to know about what is the stock that is available, what is in position, what is not available. So we get a real-time monitoring of the drug stock and the equipment stock. There should be standard treatment guidelines we have in place, but it should be widely circulated and people should be widely trained on these standard treatment guidelines. We should also take the support of digital decision support system. I mean, we have established decision support system already available in place, but probably we shall try to incorporate these ideas into our system. And it is not just health sector which can fight this whole battle. Health sector, in terms of identifying and treating, we are just doing a small part in a bigger battle. So if we have to actually handle NCD, it is not just within the health sector, but there are other sectors which also has to come in place. And we should also look at mechanisms for screening for complications, wherein we can, I mean, as the previous speaker mentioned about using how to use teleconsultation in terms of taking an ECG and getting it, getting an opinion from the expert using teleconsultation. All these things shall be made available at PHC level so that we are not burdening the patients from pushing them from a PHC to a tertiary care center for want of screening for these complications. And with that, I would like to end my talk and open for questions. Thank you.
Thank you very much, Dr. Sudharshini. We open for questions.
Diabetes, what you are considering glycerol include or simple blood?
Currently in the system, we have only blood sugar.
What else you are charging at PHC?
At PHC, we have metformin, glebanclamide, and gliptins are also available in PHC, and we also have insulin at the PHC.
Thank you. It was very gratifying to listen to this program undertaken by the government. Two questions. Do you have data on, let's say, 1 year, how many patients remained on follow-up in care and what proportion have goals achieved, blood pressure control and diabetic control? Second is, why did you include breast cancer screening? Meaning the benefit of screening for breast cancer is so controversial, whether it really provides any meaningful benefit. Does it improve life expectancy, or it has all other problems related to overdiagnosis and overtreatment? So why did government step into breast cancer screening?
Okay. So the first question, whether we have data on regular follow-up and do we have numbers on whether they have achieved. So that was the ambition of this public population health registry. It's still under construction and we are yet to reach there. So, but that is what the government is also aiming at, to have a line list of people who are diabetic or hypertension and to have their regular follow-up data. And with regards to, breast cancer screening, again, it was based on the data saying that breast cancer is the most common cancer and people are reaching out to the centers at a later stage. Probably we would look into what you are saying and we would also. Okay. Yeah.
Good morning. As an alumnus from MMC, I'm very happy to see you here, ma'am.
Hi.
Very comprehensive summary on the NCD care services provided by the Tamil Nadu government. One first-hand experience with Makkale Tedi Marutvam. I remember interacting with very poor women in and around small villages in Tamil Nadu. So I was a little worried how they are going to follow up having their diabetic medications and hypertensive medications and getting checkups. So they were like, "Onnum paravailla, ma'am. Avangale veetukku vanduruvaanga." So like, they'll come home, not to worry, ma'am. They'll come whenever we are comfortable. They come check, give us the medications and go. So you don't have to worry about that. So I was very happy with the initiative that it's reached some remote villages in Tamil Nadu. Another thing is, I hope all the challenges that you have stated get slowly addressed. And again, regards to the UG curriculum, I am not sure whether I'm the right person to say, but like when I was in MMC as well as in PG in Jaipur, so I remember faculty saying that the final year questions for medicine is still valvular heart disease and all. So we should include NCDs in our curriculum. Maybe the focus here is different, but there we used to still have valvular heart diseases, liver cirrhosis and all. And also you had mentioned that you're doing some work in Chengalpet. Ma'am, could you just elaborate on the work there, ma'am?
Okay, so thank you for the comments. And at RUSEC, RUSEC is basically an NGO which is working for Dalit women. It was an organization which was, founded by 13 Dalit women of that area. So the very purpose of RUSEC was to provide social reforms and education. When it was started 40 years ago, most of the women, they were not educated, they were illiterate, and they wanted a place for them to have a basic literacy, at least to know what they are signing in for. So that was the very objective when RUSEC was founded. But then women there felt that there is a need for a hospital to be, a clinic to be available there, because they were facing a lot of challenges with regards to meeting out their health needs. So then RUSEC clinic was also established. Earlier, the clinical services that was provided by RUSEC were MCH care services, but then with the other PHCs getting strengthened, RUSEC decided that no more, we have to duplicate whatever services that are provided by the government. So therefore, we focused on NCD care services. So currently, the population who come to RUSEC clinic are those with NCD, like diabetes and hypertension. And RUSEC also works for domestic violence, and it also works for improving the livelihood of women over there, the marginalized women over there.
Yes, ma'am. Thank you, ma'am. Ma'am, one more question. So can you just tell about this village health workers? So how do you recruit them? How do you train them? And then are they ASHA? What happened to the ASHA workers?
In Tamil Nadu, only in certain places we have ASHA workers. So because we already have this village health nurses who are regular government employees in place. But this women health volunteers are actually volunteers. They are coming from a self-help group within that village. They identify, they volunteer to provide these services. They basically, they would come under the other department, women and social welfare department. They are under that department, and health department, in collaboration with the social welfare department, are recruiting this women health volunteers. They are being trained on the services that they have to render. And for every services, there is a package of honorarium that is attached to it, and they would be paid the honorarium from the health department to the social department, and from there they would get the honorarium. So because of this huge cycle, they also don't get the honorarium on time. So there is a lot of time delay. So yeah, yes, sir. Sorry, sir. Oh yeah, yes, sir. I know. Yes, sir. Yes, sir. Yes, sir. Probably we are taking from that, sir.
A very quick question, ma'am. I'm a geriatric registrar in CMC, posted in DRP now. Few things that I've noticed is like COPD is very terribly managed because there's no inhalers. Omeprazole and Augmentin, they look exactly the same. So an elderly gentleman will not know which one is which drug. Some things like this. So question is there a way of auditing how, and for example, an orthopedician would sit and give, let's say amlodipine, poorly managed hypertension by a person who is not a physician, because they don't know. So is there a system of educating doctors in, for example, not giving diclo injection for an elderly osteoporotic lady with knee pain? Is there a system of auditing what drugs are being given and how they are given? Like insulin, how it's just given into the hand rather than some cold chain being there. So simple things like this would make a lot of difference. Is there a way of giving back feedback so that it is implemented? And how do we add to the formula, like adding inhalers to the drug? Yeah.
Okay. So whether we have any auditing mechanisms in place, currently no such good auditing mechanisms are available in place. So we have to establish one. And regarding, look-alike and sound-alike drugs, there are mechanisms within the pharmacy wherein we are trying to sort these look-alike drugs and sound-alike drugs. That is the level of intervention that is being done at the pharmacy level. And with regards to updating the non-physicians on NCD care, I think largely it is left to the individuals to get themselves updated, and there is no current system in place to train them on this regard. At least with regards to MTM, all the PHC medical officers are given training on whenever there is a change in the protocol, they are being trained on the protocol, the revised protocol. So that is what is in place currently.
Lots of questions. I'll just take some that have come on the chat box. There is talk that people are not valuing services since it's given at their doorstep free of cost. Is this true?
People who need it daily, they definitely value it because they are, many of them who come to RUSEC itself, they can't afford to even the generic drugs that is being offered at a lower cost. So people who need it, they value it the most.
And another question, ma'am, from your experience, how could we address the inequity, NCD, and poverty cycle within the constraints of people's lives?
That's the bigger talk of the entire conference. I think, lot of issues from multiple stakeholders. It is not just health which can work on it.
Yeah, I think this is definitely a topic we could all go talking on about, but I think we've come to the end. Thank you very much, Dr. Sudharshini, for a very comprehensive talk.
Thank you, Dr. Sudharshini. We request Dr. Divya to please felicitate Dr. Sudharshini with a memento on behalf of CMC. Thank you very much. We thank Dr. Divya for moderating the session.